We can move to the next presentation.
Yeah, Professor V. Rajashekar, evidence-based medicine in spinal procedures. Professor Rajashekar, please.
Yeah, my presentation is recorded already.
Yeah.
Can you please play that? It's for good morning. I would like to begin by thanking Professor Ramani and Dr. Sahu for inviting me to give this interesting talk on evidence-based medicine approach to spine surgery. Most of you probably believe that evidence based medicine is a recent concept, and therefore, most of the evidence regarding spine surgery was accumulated in the last 2 or 3 decades. This is not so. In fact, we have randomized controlled trials in spine surgery going as far back as 1976. That's almost 45 years ago. So, here is a list of 6 such RCTs which were done to evaluate the results of anterior cervical microdiscectomy versus anterior cervical discectomy and fusion. And as you can see, all these 6 randomized controlled trials showed that the outcomes following simple discectomy were equal to or even better than that achieved through ACDF. And this is not only at a short term follow up of a few years, but the follow up in some of these RCTs was up to about 5 to 6 years. So, some of these authors recommended that fusion is not necessary following anterior cervical discectomy. A more recent study in 2007 came to the same conclusion, where the authors concluded that the technique of reconstruction plays no role in the clinical results of a patient undergoing surgery for cervical disc disease. Therefore, the AANS CNS joint spine section recommended in their guidelines that the class 1 evidence exists for the results of both ACD and ACDF being equivalent, and therefore both are recommended as equivalent treatment strategies for one level cervical disc disease. Even the Cochrane library uh, reviews show that ACD and ACDF are equivalent, whether one uses cages or plates, with regard to the ultimate outcome. Finally, there is a trial that was conducted in 2019, which also put in arthroplasty into one of the arms of the trial. And even this trial, at the end of 2 years follow up, showed that the results of a single level ACD were the same as that of ACDF or ACD with arthroplasty. In other words, one need not implant any intervertebral device after doing a simple anterior cervical discectomy. We'll come back to this data a little later on in my talk. So I want to move forward to some of the very important randomized control trials that most of you may be familiar with, or may not be so familiar with. But this is one of the so-called landmark, or rather I would say a notorious trial, the Nssa 2 trial for acute spinal cord injury. And most of you probably believe that it showed that methylprednisolone improves outcomes in acute spinal cord injury when given within 8 hours of injury. But not many of you may be aware that the initial time limit for administering methylprednisolone was within 12 hours of injury. And at that time point, actually, there was no difference in the outcomes between methylprednisolone and placebo at a 1 year follow up. So, what are the issues with this trial? The problem is that the authors manipulated the data. They did what is called as a post hoc multiple subgroup analysis. Up to 27 subgroups were created in order to try to get a statistically significant difference. And this is referred to as statistical manipulation or p-hacking. We'll talk about another important randomized control trial, the SPORT trial, which was done for symptomatic lumbar disc disease. And this concluded, much to the disappointment of us surgeons, that there was no difference in outcomes between surgery and conservative therapy in patients with symptomatic lumbar disc disease if we were using the intention to treat, as it's called, ITT analysis. But surgery gave better results when using what is known as the as treated analysis. And why is that so? The problem is that at 3 months, only 50% of those assigned to the surgery arm underwent surgery, whereas on the other hand, 30% of those assigned to the conservative therapy underwent surgery, what is known as a high crossover. The SPORT trial highlights one of the most important problems in doing randomized control trials in any surgical field, and more so with spine surgery. That is, patients are unwilling to adhere to the arm that they have been allocated. So, that is, in other words, patients who have been allocated to the surgery arm may not undergo surgery if their pain is mild, whereas those who are allocated to the conservative therapy may undergo surgery in spite of being allocated to the conservative therapy group because of severe pain. And this brings us to the difficulties in performing RCTs in these patients. I want to finally highlight a group of patients that we deal with on a regular basis as spine surgeons: lumbar canal stenosis with or without spondylolisthesis. Undoubtedly, probably the number one indication for spine surgery worldwide. So, is there good data for this group of patients? Yes, there is. So, we will begin with these two randomized control trials that were published back to back in NEJM in 2016. The first is a trial that came from Sweden on 247 patients with back and leg pain due to lumbar canal stenosis. They didn't bother whether there was any listhesis or the degree of listhesis. They just allocated patients to either decompression or fusion. And interestingly, at 2 years and 5 years, there was no difference in the outcome in these two groups of patients. The reoperation rates also, interestingly, were about the same, 22%. And not surprisingly, the length of hospitalization was longer in patients who underwent fusion surgery. The article that accompanied this article in the same issue of the journal came from the United States, and they came to a slightly different conclusion. This had a much smaller cohort of patients, 66 patients. They only chose patients with grade 1 listhesis, same age group, 50 to 80 years. The two arms were laminectomy versus posterolateral instrumented fusion. At 2 and 4 years follow-up, the ODI was the same in both groups, but the SF36 PCS was slightly better in the fusion group. But what stood out dramatically was the reoperation rates. The reoperation rates were higher in the decompression group, 34% versus 14% in the instrumented fusion group. Again, the length of hospitalization was higher in the fusion group. So there was a complete contrast in the results to some extent, and the American authors suggested that patients should undergo fusion rather than just decompression when they have grade 1 listhesis. Now, to break the tie, as it were, is this paper that has come out a few weeks ago, again in NEJM, now from Norway. Large number of patients, 262 patients. This time, patients had listhesis more than 3 millimeters, two arms, decompression versus instrumented fusion. And what do the results show? 2 years, the ODI outcomes were the same. Reoperation rates were slightly higher in the decompression group, but not too much higher, about 3% more. And so these authors concluded that patients with listhesis of more than 3 millimeters should undergo decompression alone. So here is the dilemma that we face when we evaluate evidence in uh, any surgical field or and spine surgery in particular. So-called good quality RCTs seem to be reporting different or contrasting results. So therefore, it is important that we evaluate each RCT on its own merits and decide whether the results of that particular RCT are appropriate for our patient group. In other words, do our patients resemble those in all aspects, age-wise? Remember, patients between 50 and 80, so don't apply them to somebody who's 30 years old. So and so on and so forth before you decide that you should follow the conclusions or the recommendations that accrue from the RCT that you have looked at. Another RCT that is relevant to spine surgeons from closer home in Mumbai on patients who had tuberculosis of the spine. A very important topic. What is the duration of anti-tuberculous therapy that should be administered to these patients? We typically give 18 months of ATT, but these authors decided to evaluate 6 versus 12 months of ATT and looked at outcomes 24 months after completion of therapy. And what they concluded was that the outcomes were the same. There are some limitations to this study. It was underpowered. More patients in the 12 months regime underwent surgery, and the definition of cure was subjective. They didn't rely on MRI because they believe that MRI is not reliable to distinguish between just sterile residual soft tissue and infection. So I've come to the final point. Do we really follow the evidence when we have evidence? For example, there is enough and more evidence that simple anterior cervical discectomy gives the same results as ACDF. But how many of us stick to just ACD? I guess almost none. Everybody does ACDF and maybe even an artificial puts in an artificial cervical disc. I want to leave you with this slide to illustrate that EBM is not just the blind application of best external evidence. It occurs at the intersection of these three circles: individual clinical expertise and experience, patients' values and expectations and affordability in our country, and the best available external evidence that's been critically evaluated. The intersection of these three, as shown in this diagram, is evidence-based medicine. Thank you for your attention.
Thank you, Dr. Rajashekar. The wonderful lecture as always. We
Thank
really
you.
appreciate and we follow what you say most of the times. So the wonderful lectures. Thank you, sir. Thank you very much. Is
Thank you.
there any question?
If there is none, I just want to make one more comment
Sir, sure, sure.
that as I grow older, I become more cynical because I wonder why this evidence is being gathered and even being published. For example, in lumbar canal stenosis with listhesis, how many of us are willing to just do a simple decompression without fusion? Although evidence is clearly pointing, especially in the older age group, 50 to 80 age group, that just simple laminectomy is as good as putting in rods and screws and grafts and so on and so forth. So I really don't know that should we be keeping on doing these controlled trials at all if nobody is going to end up following them. Thank you.
Sir, you are 100% correct. The problem is it, the problem with many of the newer neurosurgeons or the surgeons is if they follow the RCTs correctly, their own colleagues will criticize them and they say that they are not doing these procedures because they don't know how to do it. So to remain in the competition, they do it.
But competition
Not
is amongst
justified, but
amongst surgeons, or it should be amongst patients?
yeah, it should be with the patient, with the
Who does
benefit of
better?
the
which
patient.
which patient does better with which procedure? It should be. Anyway, I leave it at that. I know we won't solve this problem.
Sir,
Thank you,
sir.
thank you again.
Can I ask one
Dr.
question?
Moda,
Yes, Abhay.
unmute yourself,
Yes.
Dr. Moda.
Yeah, can I, sir? With,
Abhay, yes, Abhay.
yeah. Sir, I agree your all statements, sir, with all due respect to you. If I can put in this way, in my clinical career, the last question you asked, a patient with the lumbar listhesis, I think you're talking about grade 1 listhesis, sir, where the evidence is clearly now.
Interestingly, Abhay, is actually the last trial they didn't care about. They just said more than 3 millimeters. So it could be grade 2 also. But
Okay.
they didn't care. They just said more than 3 millimeters. Doesn't matter. Yeah, carry on. Yes. Grade 1, older patient, 50 to 80.
Yeah, grade 1 older patients, also in patients whom we had done a good decompression itself. I have seen in my career as well, some of them coming, not all of them, at least about 10 to 15% of them coming back after about 2 to 3 years with further worsening back pain. And again,
I get your question, but
Yeah.
can I just say one point for that? But
Yes.
for those 15%, you are subjecting the other 85% to fusion.
correct, sir.
You understand the point?
I agree.
They are not saying there is no redo surgery. They are conceding. Actually, it's a little higher in the decompression group, 13 versus 10 or so.
Yeah.
But for that extra few percentage gain, you are subjecting a huge number of patients to unnecessary instrumentation with its own complication. Duration of hospitalization is longer, morbidity is longer, cost is more. I haven't put in all that data. That's worth thinking about. That's all.
Yes, sir, I agree. But what happens is, sir, it comes in your mind when the patient comes back to you after about certain years and tells you that, yes, doctor, you have done the procedure, but I have not, again, I come back with the thing. Then it's difficult to convince them for a procedure.
Okay. Now I
In our mind, sir. That is, again, I'm sure many of surgeons
Yeah.
like me are facing the same dilemma. Why I should have done it before itself, the fusion, and there is a clear-cut listhesis. There are some evidences prior with where the listhesis, in a listhesis, it always has to be fusion. That comes in the mind, and we go through that stage. And I'm sure as I get older, things might change. I think it's a career in the surgeon's thing, which also makes a lot of difference here, sir.
I agree.
I think the experience what he gains as he goes on makes a difference, sir.